Hey everyone, today we are talking about the heart, and we're going to focus on the anatomy of the heart in this lecture video. And then in a future video or in class, you'll learn more about cardiovascular function and we'll look at the cardiac cycle specifically. So, you should all know by now where the heart is located because this has been covered in your lab course. But let's take a moment and just remind ourselves that the heart is located behind the rib cage and sternum off to the left side. You can see it's kind of sort of from rib 2-ish down to the intercostal space below 5 and 6 is the general vicinity, with the apex of the heart right there in that intercostal space, and the base of the heart up closer to the top behind the sternum here. We know we have 4 chambers. We're going to have 2 atria at the superior aspect at the base of the heart, and we're going to have 2 ventricles at the towards the apex or the inferior region of the heart. The ventricles are going to be much more muscular. The atria are going to be a little more thin-walled, and so right away that gives us some hints about their function. We also can think about the heart like a 2-pump system because one circuit of the heart is going to be focused on pulmonary, so sending blood to the lungs and bringing it back. And then the other circuit of the heart is going to concentrate on sending blood out to the body and then collecting it back so that it can then be sent to the lungs. So that's why we often call it a 2-pump system. Also, I should point out that when we're talking about its location, it is in the thoracic cavity. In particular, it's located in the mediastinum, that sort of space between the pleural cavities. And then within that, it's within the pericardial cavity. Any kind of inflammation of the pericardial sac would be pericarditis, which may lead to a cardiac tamponade. In other words, the heart isn't going to be able to expand as much as it normally would, and that would not be a good thing. All right, so this is all let me just pop right down here into this picture. I'm going to blow it up a little bit. So just to remind ourselves, because this is something from A&P1 lab, that we have those serous membranes that line cavities with 2 layers, a visceral layer and a parietal layer. So here in this image, we're able to see that parietal layer on the outside, the actual pericardial cavity, and then the visceral layer or the pericardium around the heart. So it's just a great reminder of things you've already learned. And if we dig into the wall of the heart a little bit more, we'll find that it has 3 layers. So we were just talking about the outside. So there's that pericardium with the parietal layer of the serous membrane. And then if we come across the pericardial space, we'll come to the visceral layer of that serous membrane. And we could even think about all of these specific tissue types that are in each of those layers. So you can see the parietal layer is going to have a layer of epithelial tissue supported by some loose areolar connective tissue. And on the very outside, there'll actually be some fibrous tissue, some dense fibrous tissue. Give the whole thing a little strength. And then on the visceral layer, again, we're going to have a simple squamous epithelium supported by an areolar connective tissue underneath. So nothing surprising there, things that you've heard and learned before. Our middle thick layer is going to be the myocardium, consisting of cardiac muscle. And remember, cardiac muscle underneath the microscope has some unique features. For one, it is striated tissue. And also the cells tend to be branched, and they have singular large nuclei in them. And also cardiac muscle is quite famous for its intercalated discs, which are where 2 cardiac muscle cells join up. Those discs are evidence of the gap junctions that are located there. They are made of an abundance of proteins, which pick up the stain, which gives us that dark mark there that we call the intercalated disc. Gap junctions, of course, are a way for chemical signals to move from one cardiac muscle cell to another. So a great form of communication. Not entirely unique to cardiac muscle, but one of the few places that you find it. And then our innermost layer will be the endocardium. Again, we're going to have a simple squamous endothelium lining the inside of the heart. That endocardium, as we call it, is essentially the same thing as endothelium, and it will be continuous with the inner simple squamous lining of the blood vessels that exit the heart and enter the heart. So it just gets a special name, endocardium, when we are specifically talking about the heart. And again, it's an epithelial layer, so it's going to be supported by areolar or connective tissue. Just making sure we remember, epithelial tissue is avascular, so it needs that supporting areolar or connective tissue because that's where the blood supply for that epithelial tissue will be. So flashback to AP1 there. All right, let's look at some of the external features of the heart. First and foremost, you want to get straight whether you're looking at the anterior or the posterior surface. I'll be honest with you, I identify the posterior surface of the heart by when I find a whole mess of vessels, and I'm like, oh, that's a posterior view. When it's a little neater and tidier, I'm like, got an anterior view. But also, the aortic arch really gives it away, right? So you should see that aortic arch rising up from behind the right atrium and crossing over the pulmonary trunk where it splits into left and right pulmonary arteries. And so then we know that we're here in the right ventricle. We have the right atrium feeding into the right atrium. We can see the superior vena cava. And we know, although we can't see it from an anterior view, that the inferior vena cava and the coronary sinus are also dumping into that right atrium, bringing back deoxygenated blood to the heart and into the pulmonary circuit. And if we move over to the left side of the heart, we can say, okay, here's the left ventricle. We can separate the right and the left because we're going to have that anterior interventricular sulcus right here that separates the two. And just peeking out over here is a little bit of the left atrium's auricle, hidden in part because more of it is around the back, and the pulmonary trunk also arches over in front of it. So those are some of the major features. I think in lab, you also went over some of these trunks that are going to come off the aortic arch. So you can think about those. You've got left subclavian, left common carotid, and brachiocephalic. And then if we flip over to the posterior side of the heart, just remember, we've now turned it over. So left is left now, like your left is the left, and your right is now the right. So that's different than our typical anatomical position. And so there's our right over here. Here's our left. We can also see the coronary sinus in between the atria and the ventricles. We have a really good view of the vessels and the left atrium at this point. So here's our left atrium with all 4 pulmonary veins, left and right, coming off. The right ones are going to be closely related to where the vena cava are going to come into the right atrium. And sitting on top of the left atrium, we can see the pulmonary artery, and arching over all of it is that aortic arch, which will become the descending aorta, which has been removed here so we can see the back from the posterior view. So these are the basics of the external features. We also want to be familiar with the blood supply because the heart, of course, is supplying blood to everyone else, all the other cells in your body, but the heart cells themselves need a supply of oxygen and glucose and all the other goodies in the blood. So that's going to be accomplished through the left and right coronary arteries. They are going to come out of the base of the ascending aorta. So as soon as it exits out of the ventricle, we're going to see those coronary arteries coming off. Of course, the left will go off to the left and the right's coming off on the right side. They will fill whenever the ventricles relax because the blood will kind of fall back down the ascending portion of the aorta, allowing it to spill out through the coronary arteries. You will note that the right coronary artery will ultimately ends up in marginal arteries that travel along towards the apex of the heart, and the left coronary artery will give rise to both the left anterior descending, which travels down that sulcus I mentioned earlier, and also the left circumflex artery, which will sort of wrap around towards the posterior of the heart, and we can see it over here. Those are the only arteries that we need to know at this level. Important to note that since these arteries are the main source of blood for the heart muscle cells, a blockage in one of these coronary arteries would cut off the blood supply to the entire region they supply. And that could definitely lead to a loss of function in the heart or a heart attack. And blockages out in these smaller branches are going to affect the tissue or the muscle tissue that is supplied by those branches. So the closer the blockage is to the ascending aorta, the greater the amount of tissue that will be impacted. And the further out a blockage is into these peripheral branches, the less heart muscle tissue would be impacted. But either way, it's, again, not a good thing. We want to have a robust oxygen and glucose supply to our heart muscle so that the heart can make the ATP it needs for contraction. Coronary artery disease is typically caused by atherosclerosis. So arteriosclerosis is like the generic term for any thickening or hardening of artery walls. The most common type of that is atherosclerosis, which is caused by lipid deposits or plaques that are in the walls of the arteries. They're not like attached to the inner wall. They're actually behind the endothelium, and they force the wall of the artery out into the passageway, which then blocks the passageway so blood can't flow through it well. So the arteries are not patent, right? They're not fully open. They're getting closed down. Some of the risk factors for developing arteriosclerosis are going to include high cholesterol, high blood pressure, smoking, being older, being male. All of these things increase your risk, and they can lead to heart attack and stroke. One way that we can treat atherosclerosis is using balloon angioplasty. So this is where we inflate a balloon inside the vessel to push the plaque and flatten the plaque back into the wall to open up that vessel. We may need to, and that's a relatively easy way to let the blood flow past. Another option would be to remove the area of damaged vessel and then replace it with a piece of vein. But that's a little bit more delicate. So one is not necessarily better than the other. They are just different, and they have different sets of potential complications and outcomes for patients. But balloon angioplasty is probably the go-to at this point. So coronary artery disease is anytime there's a blockage specifically of heart arteries. So arteriosclerosis and atherosclerosis can affect any arteries anywhere, but coronary artery disease in particular is when we have blockage of heart arteries, and that leads to coronary ischemia, a lack of oxygen to the cardiac muscle. And one thing that they can do is after angioplasty to get that vessel back open, they can put a little stent in there, which is like a little device that just kind of like a little mesh that holds open the vessel so that blood can continue to flow through. Okay, so that brings us to the internal anatomy of the heart, and we need to be able to describe the flow of blood through the heart and name the structures that the blood is passing by and whether or not the blood is deoxygenated low O2 or oxygenated high O2. So I like to always start with blood returns to the heart via the vena cava and the coronary sinus. And from there, that deoxygenated blood will be dumped into the right atrium. And then from the right atrium, it will pass through the tricuspid valve into the right ventricle. And from the right ventricle, this deoxygenated blood will go to the lungs by traveling through the pulmonary semilunar valve into the pulmonary trunk and out the pulmonary arteries to the lungs. And then that blood will get oxygenated in the lungs and it will return to the heart to the left atrium via the left and right pulmonary veins. So they will dump right into the left atrium, and that blood is now high in oxygen because it's coming back from the lungs. And it's going to pass through the bicuspid valve into the left ventricle, and then it will pass through the semilunar aortic valve and exit out of the heart via the ascending aorta into the aortic arch and down the descending aorta, and it may leave through some of these trunks that supply the head and neck region as well. So those are the major structures that blood is going to pass through. And then also while we're here, it's a great time to just point out that we have some special names for some structures associated with valves. So there's the valves themselves, which are these thin connective tissue pieces. And then they have chordae tendineae, or these strings, if you will, that will attach to the papillary muscle. And so the papillary muscles can contract and pull on the strings to open the valve, or if the pulmonary muscle relaxes and loosens up on the chordae tendineae, then the valves will be able to close. We can also spot the trabeculae carni, which are these sort of stringy looking structures in the wall of the ventricles. And then one special little structure is the moderator band down here in the right ventricle, and that will come up again in the future. Okay, so just a quick little, which of the following transports oxygenated blood to the heart from the lungs? This is just to remind you that the pulmonary veins will dump oxygenated blood into the heart because they are coming from the lungs. And that's the weird one, because arteries always go away from the heart, veins always come to the heart. Most veins are deoxygenated blood, but the exception is the pulmonary veins because they are coming from the lungs. So this is just kind of repeating what I just said, but I like to have a list when I study, so I put this here. So just a reminder that this is the sequence of events in terms of blood moving through the heart and whether or not it's oxygenated or deoxygenated. You should be able to write this list down yourself without looking it up. And if you can, then you're in a pretty good place for getting ready for a test. Okay, so we'd be remiss if we didn't spend a little bit of time talking about valves. They are really important to controlling the flow of blood through the heart. They prevent blood from flowing backwards as the heart undergoes sequential contractions and relaxations from atria to ventricles. So the AV valves permit blood to pass when the ventricles are relaxed because the chordae tendineae are loose. When ventricles contract, the blood will force valves closed between the atria and the ventricle, and the papillary muscles will tense to prevent the valves from swinging into the atria, to keep them from going too far the other way. We don't want them to be swinging doors. And if they do, that's called regurgitation, and we can hear that when we listen to the heart. The heart actually has a skeleton made of dense connective tissue, and that cardiac skeleton is really important for valve function because that's kind of what creates, I'm going to call it like a door frame, right? If you didn't have a frame around a door, there wouldn't be anything for it to shut or open against, and valves are kind of similar. So they need some kind of frame structure to open and close against. Your semilunar valves to the pulmonary trunk and the aorta are actually a little more stable because of their tripod shape. Triangles are tough. Damaged valves, on the other hand, anywhere, whether they're the AV valves or semilunar valves, can compromise cardiac function because we're likely to get regurgitation, and that means our heart isn't working as efficiently as it could. And so that is damage. If the valves are damaged enough, we may have to intervene and try to fix them. So here are some images of some of these valves. So you can see the pulmonary valve here and the aortic valve, and you can see they've got three. These are tripod style semilunar valves, so they're nice and stable. And then we have our a little bit less stable, but still functioning AV valves. We've got our right over here and our left over here. So this is our mitral or bicuspid, and this is our tricuspid on this side. So just looking down on them is a different view than when we look at them from a side view, which is maybe the more typical view. So it's just good to see them from here too, to understand how they function. I included this image of labeling the heart. I think this is a great way. This is to study and to see if you know what you need to know to get ready for a unit test. This diagram is at the end of the chapter in your textbook, but because I think you're so wonderful, I just wanted to make your life a little bit easier. And oops, I popped in the answers for you so you can check yourself. So you should definitely be able to label this heart quick as a flash. And then you know you're in a pretty good place for this topic moving forward in preparation for our unit test.